Welcome to my lecture of diabetes mellitus. In continuation with the previous talk of diabetes mellitus, today we discuss about the pathogenesis of type 1, type 2 diabetes mellitus, clinical features, laboratory diagnosis, and the complication. So, pathogenesis of the type 1 and type 2 diabetes mellitus is different. So, type 1 diabetes, as we recap to the previous talk, type 1 diabetes mellitus that occur commonly in patients under the 30 year of the age or the juvenile onset or the childhood onset. Autoimmune destruction of the beta cells is the major pathogenetic features of the type 1 diabetes mellitus. While in type 2 diabetes mellitus, these are the 70 to 80% chunk of the total diabetes mellitus, and it is also called as a non-insulin dependent diabetes mellitus. It affects predominantly in the older individual and the obese individual. So it can occur in obese or the adolescent children. Type 2 diabetes mellitus, it can occur also in the children who are the obese. In gestational diabetes mellitus, about 4% of the pregnant women that develop diabetes mellitus due to the metabolic changes during pregnancy. They revert back to normal glycemia after the delivery. These women are prone to develop diabetes mellitus later in their life. So, type 1 diabetes, it is the approximately 10% of the cases of the diabetes. It is the insulin dependent or the juvenile onset of the diabetes. So, there is a absolute requirement of the insulin for the treatment. That's why it is called the insulin dependent diabetes mellitus, IDDM. It has the two subtypes. One is the immune mediated and the second one is called the idiopathic. Immune mediated, which is characterized by the autoimmune destruction of the beta cells by the immune mechanism, while idiopathic, which is characterized by the insulin deficiency with tendency to develop ketosis, but these patients are negative for the autoimmune marker. So type 1 diabetes, there is a destruction of the beta cell mass. In the genetic susceptibility, there is a some genes that lead to the or the some HLA linkage like the HLA-DR3, HLA-DR4 or HLA-DQ locus, which predispose the type 1 diabetes mellitus. So autoimmune factor, there is a presence of the islet cell antibody against the glutamic acid decarboxylase and insulin. So GAD and insulin against the antibody against the GAD and insulin that lead to the type 1 diabetes mellitus. So insulitis, there is a lymphocytic infiltrate in and around the pancreatic islet cells, which is the features of the type 1 diabetes mellitus. And there is a selective destruction of the beta cells of the pancreas. Plus there is a role of the T cell mediated autoimmunity and the role of the other autoimmune disease like the 20% of the type 1 diabetes mellitus associated with the Graves disease, Addison's disease, Hashimoto's thyroiditis and pernicious anemia. So the some environmental factor like the some virus infection like the mumps, measles, coxsackie B virus, cytomegalovirus infectious mononucleosis, some chemicals, some dietary protein like the bovine milk protein, which share the antigenic property with the human cell surface protein, and it triggers the immune attack on the beta cells by a process of the molecular mimicry. So beta cells acts as an autoantigen and it activates the CD4 T lymphocytes. So our body will not identify the self antigen versus the foreign antigen, and similarly the molecular mimicry, which is a one of the pathogenesis feature of the autoimmune disease. So the mechanism of the beta cell destruction, the classical manifestation of the disease, hyperglycemia and ketosis, which occur late in its course, and more than 90% of the beta cells have been destroyed. Then and then this ketosis and that features of develops. The fundamental immune abnormality in type 1 diabetes is a failure of the self-tolerance in the T cells. So this is one of the mechanism for the autoimmune disease. Autoreactive T cells which survive and are poised to respond to self-antigen. The initial activation of these cells occur in the peripancreatic lymph node in response to antigen that are released from the damaged islet cells of the Langerhans. The activated T cells then traffic into the pancreas where they cause the beta cell injury. Multiple T cell populations have been implicated in the damage, but the CD8 positive cytotoxic T lymphocyte which directly kill beta cells, which is the major role in causes of the beta cell destruction. While the T helper 1 cells is the CD4 cells which may injure the beta cell by some secretion of the cytokines like the interferon gamma and tumor necrosis factor alpha. So the genetic predisposition plus environmental factor that lead to the autoantigen form on insulin producing beta cells and circulate in the bloodstream and lymphatics. Processing and presentation of autoantigen by the APC cells, antigen presenting cells, that lead to the activation of the T helper 1 lymphocyte, which is the CD4 positive T lymphocyte, and the activation of the T helper 2 lymphocyte, CD8 positive cytotoxic T lymphocyte. So the CD4 T helper 1 lymphocyte, which release the interleukin 2 and interferon gamma, that ultimately secrete the cytokines and the destruction, while the activation of the T helper 2 cells, which directly destruct the beta cells. Activation of the B lymphocyte produce the islet cell autoantibody and the anti-GAD65 antibody, which is responsible for the destruction of the beta cells and the decreased insulin secretion. So the age, this chart explains the age in the type 1 diabetes mellitus. So there is some genetic predisposition after the some year, approximately 5 to 10 years, that some precipitating events that lead to the overt immunological abnormality causes the normal insulin release, progressive loss of insulin release, then the glucose normal, and the 20 to 25 year the person develop the overt diabetes. So this is the charts of the type 1 diabetes mellitus. So while in type 2 diabetes mellitus, it constitutes about the 80% of the diabetes. It is called the non-insulin dependent diabetes or the maturity onset of diabetes. It predominantly affects the older individual and the obese adolescent children. Pathogenesis, it is also genetic factor, but the no definite and consistent gene have been identified for the development of the type 2 diabetes mellitus. So there is a multifactorial inheritance is the most important factor in the development of the type 2 diabetes mellitus. Some constitutional factors, certain environmental factors such as obesity, hypertension, level of physical activity, or the sedentary lifestyle, which play contributory role in the modulate the phenotyping of the disease. Insulin resistance, one of the most prominent metabolic features of the type 2 diabetes is the lack of responsiveness of the peripheral tissue to insulin. So insulin resistance, particularly in the skeletal muscle and liver, obesity in particular, it is strongly associated with the insulin resistance and the type 2 diabetes mellitus. So insulin resistance, which play a major role in the pathogenic development of the metabolic syndrome. So hyperinsulinemia, type 2 diabetes, or the glucose intolerance, central obesity, hypertension, dyslipidemia, that include the high triglyceride level, low high density lipoprotein level, and the increased LDL level, hypercoagulability. So these all are the related to the insulin resistance. So the major risk factor for the type 2 is the family history of the type 2 diabetes mellitus plus obesity, physical inactivity, some racial predisposition like the blacks, Asians, or the Pacific Island. So that lead to the development of the type 2 diabetes mellitus. Glucose intolerance, so the impaired fasting glucose or the impaired glucose tolerance, that lead to the type 2 diabetes mellitus. History of gestational diabetes, hypertension, dyslipidemia, polycystic ovarian syndrome, etc. So the genetic, there is a lifetime risk for the type 2 diabetes in an offspring is more than double if both parents are affected. So there is a more than 50% chance to develop diabetes if mother and father both are affected with the diabetes, type 2 diabetes. So two metabolic defects that characterize type 2 diabetes is the insulin resistance and the beta cell dysfunction. Insulin resistance, that means the decreased response of the peripheral tissue to insulin, while beta cell dysfunction is an inadequate insulin secretion in the face of insulin resistance that lead to the hyperglycemia. So decrease or the failure of the target tissue, peripheral tissue to insulin action, that is the major factor for the development of the type 2 diabetes mellitus. So here the main factor is obesity. So the obesity, this diagram explains the obesity, that here the adipocyte cells is present in the blood vessel in between the adipose tissue. So that causes the release of the free fatty acid, some inflammation and adipokines. So this substance which is released, that also lead to the insulin resistance. So this substance, adipokines, free fatty acid and inflammation, that lead to the affect the pancreatic islet cells. So initially the pancreatic islet cells, beta cells, which lead to the insulin secretion which is normal, and that lead to the blood glucose level is normal. In the second step, there is a beta cell compensation. So there is a some destruction of the beta cells occur, but the remaining beta cells try to compensate that beta cell loss. That lead to the increased insulin secretion by beta cells, and the person experience the normal or the impaired glucose tolerance. So this is called the pre-diabetes. So this condition is called the pre-diabetes, and that person have the more chances to develop diabetes in near future. And the last stage is the beta cell failure. So that is the destruction of the beta cells that lead to the decreased insulin secretion, and patient develop the overt diabetes mellitus. So these are the pathogenesis of the type 2 diabetes mellitus. So the person has genetic predisposition plus obesity and lifestyle factors that lead to the insulin resistance. Initially compensatory beta cell hyperplasia that lead to the normoglycemia, and further damage to the beta cell or the loss of the beta cell that lead to the impaired glucose tolerance, and the lately the overt diabetes developed, which is the primary beta, which is the beta cell failure or the destruction of the beta cell. Now the diagnosis of the diabetes mellitus. So diagnosis of the diabetes mellitus, which require the blood glucose level. So there is a three type of the blood glucose level which is measured in routinely in the laboratory. One is the fasting blood glucose. Second is the postprandial blood glucose. Postprandial blood glucose is the 2 hour after meal the blood glucose level, and the one is the random blood glucose. It is called the RBS. Fasting blood glucose, it is called the FBS. Postprandial blood glucose, it is called the PP2BS. And the other important laboratory investigation is glycosylated hemoglobin HbA1c, plus urine testing for the blood glucose in the ketone body, which is also a supplementary test for the diabetes. So this 3 to 4 test which is important for to diagnosis of diabetes. Other ancillary test or the other rare type of the test is the insulin assay or the C peptide level. So C peptide assay, proinsulin assay. So to differentiate between the type 1 and type 2, whether there is the endogenous synthesis of the insulin occur or not. Some test for the islet cell autoantibody, so that we discuss GAD65 and autoantibody, and the screening for the diabetes associated complication. So these are the cutoff or the criteria for to diagnosis for the diabetes mellitus. So this is the plasma glucose value. Fasting, it is equal to more than 8-hour value. So the normal fasting value of glucose should be below the 100 milligram per deciliter. So any blood glucose in between the 100 or the 110 to 125, it is called the impaired fasting glucose. And if the glucose value is more than or the equal to 126, it is called the diabetes mellitus. Similarly, 2 hours after meal, the value more than 200, it is called the diabetes mellitus, while 140 to 199, it is called the impaired postprandial glucose tolerance. And less than 140, it is the normal postprandial glucose tolerance. And the random value, it is a more than 200 milligram per deciliter. So diabetes mellitus in a symptomatic patient. So this value should be consecutively present in the 2 days plus clinical features to diagnose the diabetes mellitus. So these are the diagnostic criteria by the American Diabetes Association. So fasting plasma glucose level is 126 milligram per deciliter, 2-hour plasma glucose level is 200 milligram per deciliter, and the random plasma glucose is 200 milligram per deciliter. While glycosylated hemoglobin level is 6.5% or higher, that indicate the diabetes mellitus. So the 6.4 or lower, that is the normal glycosylated hemoglobin. Hemoglobin A1C is called the glycosylated hemoglobin. So it shows the average blood glucose level in the previous 3 months. So it depends upon the RBC life cycle. So RBC lifespan is approximately 100 to 120 days. So it indicates the level of the glucose in the past 100 to 120 days. So here the diagram or the chart shows the how the glucose level and the insulin secretion display. So the normal person, that the glucose level goes, and after eating, normally the fasting plasma glucose level is 80 to 100. After eating it becomes the 170 to 200, and 2 to 3 hour after eating it remains the constant 120 to 140. But in diabetes this level is after eating 220 to 300, and the 2 to 3 hour after eating the level is 200 plus. So the person have continuous hyperglycemia that lead to the all the complication of the diabetes. So persistent hyperglycemia that lead to the complication. So the complication of the diabetes, there is the acute and chronic complication. Acute metabolic complication is the ketoacidosis and hypoglycemic episodes which occur in due to the type 1 diabetes. In the type 2 diabetes, there is a hyperosmolar non-ketotic type of the coma which occur into type 2 diabetes. So the chronic or the late systemic complication is the atherosclerosis or the arteriosclerosis, microangiopathy, nephropathy, neuropathy, retinopathy, and the increased predisposition to develop some infection. So pathogenesis of complication of diabetes, it is mediated by the three biochemical mechanism. One is the non-enzymatic protein glycosylation, polyol pathway mechanism, and the excessive oxygen free radicals. So that lead to the damage and complication of the diabetes. So this diagram also explains the clinical picture as we discussed previously. Insulin deficiency that leads to the hyperglycemia and glycosuria. So glycosuria that lead to the vulvitis and balanitis, so increased chances of the infection. Hyperglycemia that lead to the fatigue. Glycosuria, it lead to the decreased anabolism, means the decreased synthesis and increased catabolism. So increased lipolysis, so increased free fatty acid in plasma and oxidation in liver that lead to the conversion into the ketone body and ketoacidosis and the death. Decreased anabolism that lead to the decreased synthesis that lead to the osmotic diuresis, polyuria and the polydipsia, dehydration and loss of electrolytes, so that lead to the tachycardia and hypotension and the diabetic coma, and ultimately lead to the death if not treated adequately. So increased catabolism that lead to the hunger and the polyphagia, weight loss and the lipolysis that lead to the fasting. So the person have the wasting of the muscle plus weight loss, and the person have the eating more and more food because the increased catabolism that lead to the polyphagia, and the increased urination, polyuria and the polydipsia. So this 3P is a cardinal feature of the diabetes mellitus plus level of the blood glucose. So this diagram also explains the complication of the diabetes: microangiopathy, cerebral vascular infarct plus hemorrhage, hypertension, atherosclerosis, nephrosclerosis, glomerulosclerosis, arteriosclerosis, pyelonephritis, and some peripheral neuropathy due to the damage to the nerve, autonomic neuropathy that lead to the loss of control in the bowel and bladder habit. This explains the gangrene due to the atherosclerosis of the distal blood vessels of the leg. Gangrene also predisposed to some infection due to the ischemia, and the myocardial infarction occur in case of the diabetes mellitus. Sometimes the diabetes causes the retinopathy, cataracts and the glaucoma. So it involves the all the system, mainly the eye, kidney, heart and the CNS. So this affect the vascular, metabolic and immune complication through the immune mechanism, various complication, atherosclerosis that lead to the infarct, neuropathy, nephropathy, retinopathy and the various lesion, cataract, basement membrane thickening. So one by one that we discuss briefly about the complication of the diabetes. There is a cardiovascular risk. It is approximately 2 to 4 times greater in patients with diabetes, the development of the cardiovascular disease. There is an increased risk of the cardiovascular disease. Lipid abnormality, there is an increased LDL, decreased HDL and the triglyceride rich remnant lipoprotein. Patient have also the thrombotic abnormality, so patient have increased fibrinogen level, so there is a chances of the hypercoagulability plus hypertension occur in the diabetes. Person have the diabetes have the complication in CNS, means the cognitive decline, so there will be hippocampal atrophy temporal, frontal and limbic gray matter atrophy, and the frontal and temporal white matter atrophy related to the cognitive decline, diabetic retinopathy, end-stage renal disease, neuropathy and the vasculopathy, and the some cancer risk increase. So morphologic changes in the complication of the diabetes which is found in artery is called the macrovascular disease. So mainly it affects the larger vessels. Basement membrane problem, basement membrane affect the basement membrane of the small vessel, it is called the microangiopathy. In kidney it is called the diabetic nephropathy, retina is diabetic retinopathy, neuropathy and other tissue. So the macrovascular disease, there is a persistent hyperglycemia and insulin resistance that lead to the endothelial dysfunction and the atherosclerosis and the cardiovascular morbidities. Accelerated atherosclerosis involving the aorta and the large and medium sized artery that lead to the atherosclerosis of the larger vessels, mainly the aorta, and the myocardial infarction which is caused by the atherosclerosis of the coronary arteries, which is common in the diabetic men and women. Gangrene of the lower extremities, it is due to the advanced blood vessel disease or the advanced atherosclerosis of the blood vessel of the lower extremities, which is 100 times more common in diabetes. And the atherosclerosis of the renal vessels also occur that lead to the renal insufficiency and the development of the end-stage renal disease. This is hyaline arteriosclerosis of the vascular lesion. It is associated with the hypertension, is both more prevalent and more severe in diabetics, but more not specific for the diabetes. It is an amorphous hyaline thickening of the wall of the arteriole which causes narrowing of the lumen. So this is the photograph of the atherosclerosis. So this is the large vessel, white patch of the atherosclerotic plaques. This is the cross section of the artery. Here the atherosclerosis. So there is a luminal narrowing due to the atherosclerosis plus calcification and the deposition of the foamy macrophage and inflammation in the blood vessel wall. So this photograph again explains the renal hyaline arteriosclerosis. So the small blood vessel of the kidney glomerulus and the renal parenchyma that undergoes the hyaline arteriosclerosis. Microangiopathy, it is a diffuse thickening of the basement membrane of the small blood vessel. It is the capillaries of the skin, skeletal muscle, retina, renal glomerulus, renal medulla. So that thickening of the basement membrane occur in this blood vessel. Diabetic nephropathy, the kidney are the prime target of the diabetes. The three type of the lesion occur in the kidney: glomerular lesion, renal vascular lesion, which is principally arteriosclerosis, pyelonephritis and the necrotizing papillitis. So the glomerular lesion, this is a capillary basement membrane thickening. The pure capillary basement membrane thickening which is detected only by the electron microscopy. But in advanced case we can detect through the H&E stain and some special stain, PAS stain. It begins as early as 2 years after the onset of the type 1 diabetes, and by 5 years it amounts of about to 30% increase. The thickening continue progressively. It usually lead to the mesangial widening, so increased mesangial matrix deposition, and there is a thickening of the tubular basement membrane. So diffuse mesangial sclerosis and the thickening of the tubular basement membrane that lead to the nodular glomerulosclerosis. So the renal cortex which is thickened and the tubular basement membrane is thickened is demonstrated by the special stain, PAS stain. So the diffuse mesangial sclerosis, diffuse increase in the mesangial matrix, it is typically associated with the overall thickening of the glomerular basement membrane, which is PAS positive. Expansion of the mesangial area which can extend to nodular configuration, the progressive expansion of the mesangium which correlate with the measures of the decreased renal function and the increased proteinuria. So this nodule, it is called the KW nodule, Kimmelstein-Wilson nodule, which is specific in the diabetes complication of the diabetic nephropathy. So this diagram explains the diabetic retinopathy. So increased blood vessel proliferation in the retina. So this is the hemorrhage. This is called the wool spot or the soft spot in the diabetic retinopathy. So this is the diabetic nephropathy. It is called the KW nodule or the nodular glomerulosclerosis. So this is the increased mesangial matrix deposition which is stained by the PAS stain and the some basement membrane thickening. So this photograph explains the nephrosclerosis, diabetic nephropathy. So benign nephrosclerosis occurs, so the kidney outer surface is the granular and the thickened. So this is the diffuse mesangial sclerosis, which is demonstrated by the trichrome stain. So KW disease, it is the PAS positive ovoid or spherical laminated nodule of the matrix which is situated in the periphery of the glomerulus. This diagram explains the KW nodule. So this is the ovoid or spherical nodule which is located on the periphery. So it contains the two process, fibrin cap and capsular drop. Fibrin cap, it is a prominent accumulation of the hyaline material in capillary loops, while the capsular drops, it is a prominent accumulation of the hyaline material adherent to the Bowman's capsule. So the kidney, that lead to the ischemia develop, that lead to the tubular atrophy and interstitial fibrosis, that lead to the contraction of the kidney size. So the kidney size becomes smaller. So diffuse granular transformation of the surface or the marked thinning of the cortical surface. This is the picture of the nephrosclerosis. Renal atherosclerosis and arteriosclerosis, hyaline arteriosclerosis. Sometimes the pyelonephritis, it is the acute and chronic inflammation of the kidney that usually begin in the interstitial tissue and then spreads to affect the tubule. So it is a acute and chronic inflammation of the kidney, which is more common in diabetes, acute and chronic pyelonephritis. So this cover the all the complication of the diabetes. Thank you.